So the topic of my talk today is modern antiplatelet therapy in CABG, an opportunity and not a threat. So these are my disclosures. So we're talking about patients with acute coronary syndromes, and as you all know, these are patients coming in with recurrent angina. They have ischemia, they have severe coronary artery disease, and most of these patients today, they undergo revascularization with PCI. In Sweden, it's about 90% on average, and 10% of the revascularizations are CABG surgery. So that number has gone down. I think I hear from Miguel, it's about the same numbers in Portugal. And as we all know, with the ACS, this is patients that we give antiplatelet therapy. So there's always this balance between prevention of the ischemic events versus the risk of bleeding when we increase the intensity of therapy. And you can argue what is sort of the equivalence of an ischemic event versus a bleeding event. And I will go into that a little bit in terms of CABG. So antiplatelet therapy, I will focus on this group now. So antiplatelet therapy before, during, and after CABG is one of the most important factors that determines clinical outcome, because it does affect the patency of the grafts. It affects the risk of ischemic events, both death, stroke, and myocardial infarction. And of course, it affects the risk of perioperative bleeding. So the timing of the use of antithrombotic treatment will affect both the efficacy and the safety. And having a bleeding perioperative is not a trivial thing. There are many clinical consequences for the patients. So here's a list of things that can happen. You will, of course, need more blood transfusion. And in some cases, you will need reoperation due to bleeding. You have an increased risk of infections and of renal failure, and post-operative hospitalization time will increase. And when you have bleedings, this will also lead to a higher cost for those patients. And last but not least, in an increased risk for mortality. So bleeding is important. And this is some data from my colleague Anders Jeppsson in Gothenburg, Sweden. They have looked at risk factors for re-exploration due to bleeding in our Swedish registry, Swedeheart. And they, as you can see here, there are many risk factors, of course. If you have a higher Euroscore, that increases the risk. If you have a high ECC time, that also increases the risk, but the strongest risk factor is if you have had dual antiplatelet therapy within 5 days prior to the surgery. That's clearly the strongest risk factor in this analysis. So I will focus on a few controversies and areas for discussion regarding antiplatelet therapy. So when is the optimal time to stop the treatment with antiplatelet drugs prior to the surgery in the ACS setting? So, and also, how do we handle the more potent antiplatelet drugs that we have now? And a third question, whether should we restart DAPT, double antiplatelet therapy, after the surgery in the ACS population, and when should we restart, and which drugs should we use, and what evidence do we have for doing so? I think right now there is a large variation and regional differences over the countries. So the P2Y12 inhibitors that we have now are these three, and as you can see, there are some differences which might have some importance for this topic. So both clopidogrel and prasugrel are irreversible inhibitors, so they bind to the receptor irreversibly, whereas the ticagrelor is a reversible inhibitor of the receptor, which affects the offset of the drug. And you also can see that this is an active drug, whether the other two needs activation, metabolization first. The onset of effect is shorter with both ticagrelor and prasugrel, and the duration of effect is also It's the shortest for ticagrelor and the longer for both prasugrel and clopidogrel. And the recommendations that ESC have from the 2014 on revascularization guidelines is 5 days for clopidogrel and ticagrelor, and 7 days before surgery for prasugrel. Just going through the Plato results, as you all know very well, this was an all-comer study of ACS, both non-STEMI and STEMI patients, a large study of over 18,000 patients, randomized to clopidogrel or ticagrelor, follow-up time of 6 to 12 months, primary endpoint CV death, MI stroke, and the primary safety endpoint was total major bleeding. And the main results is shown here. There was a reduction of primary outcome on 16% in favor of ticagrelor for CV death, MI, or stroke. And the safety endpoints you can see here, overall there was no difference between the two drugs, regardless of whether which bleeding definition you use. However, if you look at Plato non-procedure related bleedings, those are specifically the spontaneous ones, there was a 30% increased risk in bleeding, which is could be expected because this drug is more potent. So going back to the guidelines for patients needing surgery on antiplatelet therapy, and I'm sure you've seen this as well. So if you have emergent cases, you can't wait. You have to proceed to surgery and take the risks that are following with that. In the other spectrum, you have elective surgery. Then you can easily wait until the completion of the mandatory antiplatelet regime and with no increased risk of bleeding. But I think most of our patients today that need surgery for ACS are these in the middle, the semi-elective. So then you need a case-by-case decision. So if you have a patient where the risk of thrombosis is very high, you want to continue the aspirin, and here it says clopidogrel, but now it's changing more and more to ticagrelor. And then in the other spectrum, when you have a patient with high risk of bleeding, then you probably need to stop the aspirin and the clopidogrel earlier. We did this sub-study on the Plato material on those patients that needed surgery. And we selected those that had the last intake of study drug was within this week prior to surgery. So you can see it was 1,260 patients. First, the results on the primary outcome was this. You can see exactly the same risk reduction of 16% in these patients. We have to remember that this is a sort of post hoc analysis, so it's non-randomized comparisons. But regardless of that, you see the very consistent results. What was a bit striking here, you can see, was the effects on mortality here, where you had about 50% reduction in both CV death and all-cause mortality in those patients treated with ticagrelor. So we were interested in here you have the Kaplan-Meier curves, and it was quite striking results, and we were discussing a lot what could explain these differences. Looking at bleedings in this analysis, we did not see any difference. You can see here there are lots of different definitions of bleeding, the major, life-threatening, fatal bleeds, and so forth. And there was equal numbers in both groups. And we also looked at the need for transfusion, either any transfusion or platelets from transfusion, and so forth. No difference either in chest tube output more than 2 liters, which is a sort of accepted measure of bleeding. One thing that struck us also, we looked at the mortality by days of off-study drugs. So because it was recommended in the study that you should stop treatment at least 5 days prior to surgery for clopidogrel and 72 hours for ticagrelor. But you can see here that there were differences in mortality, especially when the study drug was stopped 2 or 3 or 4 days prior to surgery. And here you see a higher mortality, although we have to know that this is low numbers of deaths. So we did a separate analysis on these patients that actually died and tried to investigate what were the direct causes of death and also contributing factors, because someone that goes to surgery and dies can be very difficult to actually decide what was the ultimate cause of death. If you end up in the ICU for 2 weeks and you have infections and you die ultimately. But we tried to do this by a reclassification or a subclassification of all those CABG deaths, with specific focus then on two, which was bleeding and infection. And interestingly here, again, this is very exploratory, but still interesting. There were significantly fewer patients that died from bleeding versus clopidogrel, and also the same was seen for infection as cause of death. So we thought that this might have to do with when you actually stop the treatment and the offset of the drug, because as you know, the offset of drug of clopidogrel is slower than when you stop treatment with ticagrelor. So, and here you can just see the Kaplan-Meier curves for those two as well. So it was kind of interesting and a little bit trying to investigate the mechanism behind these differences. What do the guidelines say on this aspect? So here you have the ESC, the American guidelines regarding antiplatelet therapy. And you can see aspirin is recommended to continue throughout the surgery. That's no difference. For clopidogrel, you can see 5 days for the European recommendations. In the Americans, they have a little extra note saying if you need an urgent surgery, you should at least wait 24 hours. For prasugrel, it's longer. It's 7 days for both Europe and America. Ticagrelor, ESC said, first they said 5 days, then for STEMI group, they actually have a little bit liberal, so they say 3 to 5 days. Although the label says 7 days for all 3 drugs. By the way, we will have new guidelines for STEMI at ESC in Barcelona, so I'm not sure, but there might be some adjustments coming up there. So that was results from the Plato. As you know, in Sweden we have these registries that we're very proud of, and we use them a lot for quality improvement, but now also a lot for research. And so my colleague Anders Jeppsson and friends, they did a study similar to the Plato CABG, going into the registry. So I'm going to give you some results from that. So what they did, this is of course then a retrospective observational study based on prospectively collected data. So they collected all patients that underwent surgery during 2 years with ACS indication. And in Sweden, the ticagrelor, the study was published 2009, but the use of ticagrelor started in 2011-12 sometime. So you can see here they found about 2,200 patients, 1,200 treated with ticagrelor and 978 with clopidogrel. And the baseline data looked fairly similar. There were small trends to difference in age, and the time since discontinuation differed somewhat. And the proportion of the drugs stopped more than 5 days before surgery was higher in ticagrelor group. So here are some of the results. The overall incidence of major bleeding was 17.6% in the clopidogrel treated group and 12.9% in the in the ticagrelor group. This was unadjusted with the 31% risk reduction. When you adjust for differences in baseline factors, it was still a 28% reduction in risk of major bleeding. So there was a fairly similar, well, sort of, it supports the findings that we had from the Plato CABG trial. Looking at the discontinuation by time prior to surgery, you can see here now the blue is clopidogrel. The incidence of bleeding, if you look at the first 72 hours, actually there were higher rates, although not significantly, in those patients treated with ticagrelor. And important to note, they say in their paper that if you do surgery within 24 hours, it's a significantly higher risk of bleeding with those receiving ticagrelor. So you should be very careful going to surgery if you have a patient on ticagrelor within the first 24 hours, because that indicates a high risk. If you wait a little bit more, 72 to 120 hours, then you can see there was a significant lower risk of bleeding in the ticagrelor treated patients and no difference after 5 days. So this also supports the findings from the Plato. And of course, if you look at by time, here are the clopidogrel patients, the risk of bleeding goes down depending on how far from surgery you are, and the same for ticagrelor. But you can see that it's the first 72 hours that is sort of really marking high risk, and then it really levels off. So that you might take that as a support for that you could actually go to surgery earlier than with when you're on clopidogrel. I mentioned in the beginning that bleeding is it's not trivial, and this just underlines this. So if you look at 30-day mortality in patients having a major bleed from this study, there was a 14 times, almost 15 times higher risk of dying within the first months. So it's really important. So switching a little bit to the DAPT, double antiplatelet therapy, should we restart? I would like to, maybe we can have that in the discussion in Portugal, how you do that. If patients coming in with ACS, if they go to surgery, do you discharge those on aspirin or do you give them double antiplatelet therapy? It's kind of a vague. If you look at the guidelines, that you can see they recommend DAPT treatment overall for all ACS patients, and the previous guidelines in North America, they recommend aspirin only, but in the European guidelines, I'll show you on the next slide, they say that regardless of revascularization therapy, you should restart DAPT. Here you have them. It says that it should be resumed as soon as possible in ACS patients. The optimal timing of the resumption of medication following surgery remains still uncertain. And recommended the duration of antiplatelet therapy 1 year in all patients, irrespective of revascularization strategy. So the same duration for PCI and CABG-treated patients. Going back to our Swedish registry, we have a very nice registry where you can follow actually every patient that goes to surgery. Here you can see that these bars here are different university hospitals where we perform CABG, and you can see that the light blue is where patients are treated with aspirin and a platelet inhibitor. You can see there is quite a large variation between those to the right, Stockholm, Gothenburg, and Örebro, which is another city. So we don't have a sort of consistency in how we treat patients when they leave the surgical wards. Although we should remember here, these are all CABG, so it's also stable angina here, but it's still quite a large variation. What is the evidence for providing DAPT? I would say there is very little evidence. We don't have any really prospective studies. This is just some data from a meta-analysis that came out a few years ago. And you can see that the studies here are very small, low number of events. So you really have to interpret this with caution. But if you look at graft patency, for instance, there seem to be favoring double antiplatelet therapy. Here, in this case, it's aspirin and clopidogrel. And same for adverse cardiac events. It's a trend towards lower event rates. If you look at the risk of bleeding, you do see an increase by 17%. If you, well, it's actually borderline significant. And mortality, it seems like it's somewhat lower in the double antiplatelet therapy, but the numbers are extremely small, so I would say you can't really judge these data. So here are the guidelines from 2014 again. So it's recommended not to interrupt antiplatelet therapy within the recommended duration of treatment, class 1C. And then you have like class 2AC, level C for all these. In patients on P2Y12 inhibitors who need to go to surgery, it should be considered to postpone surgery for at least 5 days after cessation of ticagrelor or clopidogrel and for 7 days for prasugrel. It should be considered to resume clopidogrel after CABG surgery as soon as considered safe. It should be considered to resume ticagrelor or prasugrel as well. And platelet function testing should be used to guide therapy interruption. It's a class 2AC, so it's a low level of evidence. Just one slide on, or 2 slides on another, we have cangrelor as well, which is sort of another potential option where you could actually give an IV infusion of, if you know that you have a urgent surgery coming up, cangrelor could be an interesting alternative instead of giving oral treatment. And the BRIDGE study was published some 5 years ago. It was a small study, but it was actually more looking at maintenance of platelet inhibition. But from that study, there was no sign of increase in bleeding prior to CABG, but slight excess sort of perioperatively. But I'm not sure how much this is used. In Sweden, we use it in the PCI cath lab, but not really for this indication. And here is a position paper where Miguel was also a co-author, sort of summarizing the evidence level. And you said here that bridging with cangrelor is available, if available, is recommended in high-risk patients, and it could be considered also for GP2B3A inhibitors. What's coming up more? We have a few studies, actually, I just mentioned 2 that are ongoing. This has been ongoing for a long time, the TICAB study. It's comparing ticagrelor with aspirin for prevention of vascular events after CABG. So it's not double antiplatelet therapy, so it's aspirin versus ticagrelor. It's a study of over almost 4,000 patients with the endpoint of the standard CV death, MI, revascularization of stroke. It's been ongoing. It's an investigator-initiated study. I think it's led by German investigators, but the completion is estimated in 2 years from now. So, and then the last study I'd like to mention is the TAXI trial. This is initiated from Sweden using our registries. As you know, we can now also not look with observational studies. We can also randomize patients to different treatments in the registry. So the plan here is to do a randomized trial. I can show you on 2,200 patients. So you would randomize them to aspirin plus ticagrelor or aspirin alone prior to discharge after the surgery. So this would be the first, as far as I know, prospective study on this question. You will have a 12-month follow-up, and the follow-up will be through the registry plus a few phone calls. Primary outcome will be MACE, and primary safety will be bleedings. So this will be an interesting study when it comes out, but we'll have to wait a few years. So in conclusion, rapid initiation of DAPT in ACS patients overall plays a major role for early and late clinical outcomes. That's no discussion about that. And we need risk stratification for both bleeding and for ischemic events, especially in relation to surgery. We need to optimize the time of discontinuation of antiplatelet therapy, if possible, more than 5 days, but sometimes reality looks different and we need urgent surgery. Ticagrelor, as opposed to clopidogrel, with its shorter vulnerable time period for bleeding because of the faster offset, it could be an opportunity for improved tailored therapy versus clopidogrel. And I think we should consider restarting the DAPT therapy post-operative when patients are stable. And we need more research in this area because we have very little prospective data on this specific question. So with those words, I'd like to thank you very much, and we can discuss it.